Welcome back to the deep dive. Today, we are shifting gears. We're doing something a little different, a little special, and honestly, a little urgent.
Oh, I like the sound of that.
We're calling this the last-minute lecture edition.
That sounds intense. It sounds like late nights, too much coffee, and a lot of highlighter fumes.
It is intense, but, in a good way.
Yeah.
We know that for a lot of our listeners, especially the nursing students out there, pharmacology can feel like trying to drink from a fire hose.
It's a lot. Absolutely.
Big exams are coming up, the clinicals are demanding, and you need the information now. So today we have a very specific mission. We're taking Chapter 55, Female Reproductive Health, from the 12th edition of Pharmacology, a patient-centered nursing process approach.
And we're going to tear it apart.
Metaphorically speaking, of course.
Of course, we aren't destroying it. We are deconstructing it.
Right. We're going to dismantle it and rebuild it so you understand exactly what is happening.
Right.
You're talking about a comprehensive sequential walkthrough of the entire chapter.
The whole thing.
The whole thing. We're covering the entire roadmap.
Yeah.
From preventing pregnancy to promoting fertility, managing the transition of menopause, and finally, protecting bone health.
It is a massive chapter, and it really covers the entire reproductive life cycle. What's fascinating to me is that while the clinical goals change so dramatically, preventing a baby versus making a baby.
Double opposites.
Right, or managing the end of fertility, the hormones involved are often the same players. It's the same cast of characters, just, reciting different lines.
Exactly. So here is the roadmap for you listening right now. We are going to start with contraception, the pills, the patches, the rings.
All of it.
Then we'll pivot to disorders like endometriosis and irregular bleeding. From there, we go to fertility drugs, then menopause management, and finally, osteoporosis.
And just a quick disclaimer before we dive in, we are sticking strictly to the text provided in Chapter 55. This is for educational purposes to help you understand the pharmacology as it's presented in your source material.
No medical advice here.
None at all. We aren't going off script. We are just helping you ace this specific material.
Right. So grab your highlighter or just turn up the volume, and let's get into part one. Drugs used for contraception. Specifically, combined hormonal contraceptives, CHCs.
CHCs, yes. These are the absolute workhorses of contraception. And when we say combined, we mean they contain two distinct hormonal components, a synthetic estrogen and a progestin.
Okay, so let's unpack the why first. How does taking these two hormones actually stop a pregnancy? Because I think the average person assumes it just, creates a toxic environment for sperm or something.
Right, or that it just zaps the egg.
Yeah, but the physiology is way more sophisticated than that.
It is. It's essentially a trick. You are hacking the body's natural feedback loop. The estrogen component, which is usually ethinyl estradiol, and the progestin, they work together to suppress the pituitary gland.
Okay.
They send a signal to the brain that says, hey, we have plenty of hormones here, you can relax.
And when the pituitary relaxes, what happens? What does that stop?
Well, it stops releasing two critical hormones, FSH, which is follicle-stimulating hormone, and LH, luteinizing hormone.
And the LH is the key.
LH is the key. Without that big surge of LH in the middle of the cycle, there is no ovulation.
So the egg never leaves the garage.
Exactly. The egg never leaves the ovary. We call this a drug-induced anovulatory cycle. If there is no egg released, there is nothing for sperm to fertilize. That is the primary mechanism.
Okay, primary. But you said the drugs have backup plans.
They do. Nature loves redundancy.
Okay.
So this is a multi-layered defense system.
Right.
The progestin component also thickens the cervical mucus. Think of it like putting up a brick wall or a very, very sticky gate that sperm just cannot penetrate.
So even if some sperm get in, they hit a dead end.
A very sticky dead end. If they can't get through the cervix, they can't get to the fallopian tubes. And then finally, the drugs thin the endometrium. That's the lining of the uterus.
So even if, by some miracle, an egg were somehow released and somehow fertilized,
it would have a very hard time implanting. The soil, so to speak, isn't ready. It's a hostile environment for implantation.
Okay, so three mechanisms.
Yeah.
You prevent ovulation, you block sperm entry,
Yeah.
and you prevent implantation.
It's a solid defense.
That is a solid defense. Now, I noticed the text goes into a lot of detail about generations of progestins. This feels like one of those things that's easy to gloss over when you're studying late at night, but why does it matter?
It matters because of side effects. It really does. The science of progestins has evolved over decades. The first generation progestins, like norethindrone, they've been around forever. They work, but they tend to have what we call androgenic effects.
Androgenic meaning testosterone-like, so male hormone effect.
Precisely. They can activate androgen receptors. So patients might complain of acne, oily skin, maybe some unwanted hair growth, hirsutism, or even weight gain.
Okay.
So as we move to second and third generation, scientists try to reduce those side effects. But the fourth generation is where we see a specific and really important shift.
And we are talking about drospirenone.
Yes, drospirenone. This is a fourth generation progestin. It's unique because it has minimal androgenic effects, so it's actually good for acne. But it has a specific chemical lineage you need to know about. It is an analog of spironolactone.
Wait, spironolactone? The diuretic.
Yeah.
Heart failure drug.
The very same. And what kind of diuretic is spironolactone?
It's potassium sparing.
It's potassium sparing.
I see the red flag waving. If it's potassium sparing, that means it keeps potassium in the body.
Correct. So the risk with drospirenone is hyperkalemia, that's high potassium levels. So if a patient is taking a CHC containing drospirenone, and they are also taking other drugs that increase potassium.
Like an ACE inhibitor for blood pressure, or maybe even just daily NSAIDs like ibuprofen.
Exactly. You have a potential and dangerous interaction. High potassium is no joke for the heart.
So for the nursing students listening, if you see a patient on Yasmin or Yaz or any drospirenone pill, you need to be thinking about their kidneys, their other meds, and their potassium levels.
Absolutely. That is a crucial clinical pearl. It's not just birth control. It's a drug that alters electrolyte balance.
Okay, let's talk about the pill regimen itself.
Yeah.
I feel like there's a lot of confusion about the period women get while on the pill. The text calls it pseudomenstruation.
Yeah, that sounds fake.
It does.
Because biologically, it isn't a true menstrual period. In a standard 28-day pack, you usually have 21 days of active hormones and then 7 days of inert or sugar pills.
The placebo pills.
Right. During those 7 days, you aren't taking any hormones. The levels in your blood they drop.
And that drop is what triggers the bleed.
Right. The uterine lining, which was being supported by the hormones, suddenly loses that support, so it breaks down and sheds. We call that withdrawal bleeding.
So it's not shedding a thick lining that was preparing for a baby. It's just shedding because the drugs stopped.
It's a mechanical reaction to the lack of drugs.
Exactly.
And because the lining doesn't build up as much as it would in a natural cycle, the bleeding is usually lighter and shorter.
Which is a benefit for many people.
A huge benefit. And interestingly, the text mentions that researchers have established that this monthly withdrawal bleeding isn't actually necessary to maintain a healthy uterus.
Which explains why we now have continuous use pills where you just skip the period altogether.
Right. You just take active pills every single day.
Yeah.
There's no drop in hormones, so there's no withdrawal bleed. This is fantastic for patients with, say, heavy periods, menstrual migraines, or endometriosis.
But even within the monthly pills, you have different varieties. You have monophasic versus multiphasic.
Right. Monophasic means every single active pill in the pack is the exact same dose. Simple, steady state.
Easy to remember.
Very. Multiphasic, and you'll see biphasic, triphasic, even fourphasic, means the doses of estrogen and progestin change throughout the month.
And what's the point of that?
Well, the idea is to mimic the natural fluctuations of the menstrual cycle more closely. The hope is that this can reduce side effects, especially breakthrough bleeding.
Okay, let's move away from the oral pills for a second and talk about the other routes because the safety profiles change, and I think this is where people get tripped up. Let's talk about the transdermal patch.
Okay, the patch. It contains ethinyl, estradiol, and norelgestromin. You stick it on the skin buttocks, stomach, upper outer arm, or upper torso, and you change it weekly for 3 weeks.
Then 1 week off, which is when you have the withdrawal bleed.
Exactly. Simple enough. But there is a major warning label attached to this one, a really big one.
A boxed warning.
Yes. The patch has a boxed warning regarding VTE venous thromboembolism, blood clots.
But why is the risk so much higher with the patch than the pill? Isn't it the same drug?
It's the delivery method. It's all about pharmacokinetics. With the pill, you swallow it, it gets digested, it's absorbed, it peaks in your blood, and then the level drops off. It's a peak and a trough every day. With the patch, you have a constant, steady delivery of estrogen 24/7. There's no trough. And the text states that women on the patch are exposed to about 60% more total systemic estrogen than women on a typical oral contraceptive.
60% more. That is a huge difference.
It is. And since estrogen promotes clotting factors in the liver, that higher total exposure increases the risk of DVT and PE. It's significant.
And there's another limitation too, right? Something about weight.
Yes, the text mentions a cutoff. Clinical trials showed the patch is less effective in women weighing more than 198 pounds or 90 kilograms.
So it might not even work as well.
Right. So if you have a patient over that weight limit, the patch might not be the right choice, both for efficacy and potentially for safety.
Okay, that's really good to know. What about the ring, the transvaginal ring?
The ring, which has ethinyl estradiol and etanogestrel, is inserted into the vagina for 3 weeks, and then it's removed for 1 week.
Same 3 weeks on, 1 week off schedule.
Yep.
It releases hormones locally, but they are absorbed systemically. The interesting nursing instruction here is about what happens if it falls out.
The 3-hour rule, right?
Yes, exactly. If the ring is expelled, maybe during intercourse or a bowel movement, it can be rinsed with lukewarm water and reinserted. As long as it had been out for less than 3 hours, efficacy is maintained. No backup needed.
And if it's been out for longer than 3 hours,
Then you have a problem. You reinsert it, but you absolutely need to use backup contraception like condoms for the next 7 days.
Okay, so for the patch, we're watching out for weight and clots. For the ring, we're watching out for timing.
Good summary.
And speaking of watch out, we need to talk about the scary stuff, the side effects for all of these.
We categorize these by whether they are caused by too much estrogen, too much progestin, or a deficiency of either. This is a great troubleshooting framework for nurses.
Okay, let's break that down. If a patient comes in feeling sick, how do we know which hormone is the culprit? So if they have nausea, breast tenderness, fluid retention, or those sort of vascular headaches, that points to estrogen excess.
Okay. And if they're just hungry and tired?
Increased appetite, weight gain, fatigue, depression. That sounds more like progestin excess.
And what if they are deficient? What does that look like on the flip side?
Deficiency usually shows up as breakthrough bleeding, so bleeding when they shouldn't be.
Right.
And you can even break that down further. If the bleeding happens early in the cycle, say days 1 through 14, it's likely an estrogen deficiency. The estrogen isn't strong enough to stabilize the lining.
And if it's late in the cycle?
If it happens late in the cycle, days 15 to 21, it's likely a progestin deficiency. The progestin isn't maintaining the lining properly.
That is a very, very helpful diagnostic guide. But the biggest safety teaching for any nurse and any patient is the AC acronym.
This is non-negotiable. If you are taking CHCs, you must know ACE. It stands for the serious cardiovascular side effects.
Let's spell it out. A is for.
A is for abdominal pain. And this isn't just a tummy ache, we're talking severe pain. It could indicate a liver tumor or a clot in the abdominal vessels.
Okay. C is for.
C is for chest pain or shortness of breath. This could be a pulmonary embolism or a heart attack, a true medical emergency.
Yeah.
H is for headaches, specifically severe, sudden, or persistent headaches that are different from your usual ones. This could mean a stroke or severe hypertension.
And E.
E is for eye disorders. Blurring, double vision, or a complete loss of vision. This signals a clot in the eye or a stroke.
And finally, S.
S is for severe leg pain, usually in the calf or thigh. This is the classic sign of a deep vein thrombosis, a DVT.
So if a patient has any of those, they need to stop the medication and see a provider immediately.
Immediately. Do not pass go. Do not collect $200.
And who shouldn't take these drugs at all? Who are the absolute contraindications for?
Well, known pregnancy, obviously. But the big ones are a personal history of VTE, liver disease, because the liver has to metabolize all these hormones. Breast cancer, because it's often estrogen sensitive. And this is the big one, women over 35 who smoke.
Smoking plus age over 35 equals a massive increase in cardiovascular risk.
It's a boxed warning. The risk of stroke and heart attack goes up drastically. It is simply unsafe.
Okay, so let's pivot. Not everyone can take estrogen. Maybe they have a history of clots. Maybe they are breastfeeding. Maybe they are smokers over 35. What do?
They go to part 2 of our outline, progestin-only contraceptive.
The minipill.
Yes, the POP, or progestin-only pill. Since there's no estrogen, the mechanism is a little bit different. It primarily works by altering that cervical mucus, making it thick and viscous, and interfering with the endometrial lining.
But does it stop ovulation?
Inconsistently. The text says it only stops ovulation in about 50% of cycles.
Okay, hold on. If it doesn't consistently stop ovulation, the margin for error must be way smaller.
Much, much smaller. With the combined pill, you have a little bit of leeway if you're a few hours late. With the mini pill, there is a strict 3-hour window for dosing.
Wait, we had a 3-hour rule for the ring, too. This is different.
It's a different rule. For the ring, it can be out of the body for 3 hours. For the mini pill, if you take your pill more than 3 hours late.
More than 3 hours past your scheduled time?
Yes. The risk of pregnancy increases significantly, and that's because the cervical mucus can thin out that quickly.
Wow. So if I usually take it at 9 a.m. and I forget and take it at 1 p.m.,
You are at risk. You missed the window. The guidance is to take the pill as soon as you remember, but you absolutely need to use a backup method for the next 48 hours.
that requires some serious discipline. What if they want something lower maintenance than that?
Then we look at the long-acting options like depot-medroxyprogesterone acetate, the shot, DMPA.
Also known as Depo-Provera.
Exactly. It's given intramuscularly or subcutaneously every 11 to 13 weeks.
So 4 times a year, highly effective, discreet. But there is a major boxed warning here regarding bones.
A huge one, yes. DMPA suppresses the whole HPO axis so well that it creates a hypoestrogenic state. And estrogen protects our bones. So when you are on the shot, bone resorption, that's the breakdown of bone, can exceed bone formation. This leads to a loss of bone mineral density.
Which is not good.
Not good at all. The FDA recommends limiting use to 2 years unless there are no other suitable options.
2 years. That's not very long.
It's not. And while a patient is on it, nurses must encourage calcium and vitamin D supplementation and weight-bearing exercise to try and mitigate some of that loss.
What about the implant, the one that goes in the arm?
Right, the single rod implant. It's inserted subdermally in the upper arm. It releases etonogestrel for up to 3 years. A cool detail in the text is that it contains barium.
Barium. Why on earth would it contain barium?
So it's radiopaque.
Oh, so you can see it on an X-ray.
Exactly. If it migrates, or if for some reason you can't feel it under the skin to remove it, you can find it on an X-ray. It's a really smart safety feature.
That is smart. Okay, let's touch on emergency contraception, or EC. There are so many myths floating around about this.
The most common one is that it causes an abortion. It absolutely does not. The text is very, very clear on this. EC, like Plan B, which is levonorgestrel, works by preventing or delaying ovulation.
So it stops the egg from being released in the first place.
Yes, it's a high dose of progestin that stops the LH surge. If the egg isn't released, it can't be fertilized.
So if I'm already pregnant, if fertilization and implantation have already happened,
Then C will not disrupt it. If there is an established pregnancy, it will not harm it. It is not an abortion pill. It acts before a pregnancy can even begin.
and timing is everything here.
Timing is critical. It should be taken as soon as possible, ideally within 72 hours of unprotected intercourse. It can work up to 120 hours, but the efficacy drops significantly over time.
Any key nursing tips for this?
Yes, big one. High doses of progestin can cause significant nausea and vomiting. It's a good idea to suggest taking an anti-nausea medication, like an over-the-counter antihistamine, about an hour before taking the EC.
That's a great tip. All right, that covers the preventing pregnancy part of the chapter pretty thoroughly. Now let's move to part 3. Drugs used to treat disorders in female health. Because these hormones aren't just for birth control.
Not at all. Let's start with irregular uterine bleeding, specifically amenorrhea, which is the absence of periods.
And the text distinguishes between primary and secondary.
Right. Primary amenorrhea is if you've never had a period by age 14 without developing secondary sex characteristics, or by 16 if you have. Secondary is if you used to have regular periods, but then they stopped for 6 months, or for the duration of 3 of your typical cycles.
And the text mentions a really interesting diagnostic tool called the progestin withdrawal test. How does that work?
It's a challenge test. It's a way to see if the whole HPO axis, the hormonal highway from the hypothalamus to the pituitary to the ovaries, is intact.
Okay.
You give the patient oral progestin for about 5 to 10 days, and then you tell them to stop. When you stop, their progesterone levels plummet.
And that drop should trigger a bleed, just like the placebo week in a birth control pack.
Exactly. If the patient bleeds within 7 to 10 days of stopping the progestin, it tells you 2 very important things. 1, her ovaries are producing enough estrogen to have built up a uterine lining in the first place.
Yeah.
And 2, her uterus is capable of bleeding. There's no anatomical blockage like scarring. It effectively tells you the problem is likely an ovulation. She's just not ovulating.
Which is very common in something like PCOS, polycystic ovarian syndrome.
One of the most common causes of secondary amenorrhea, yes. PCOS is a complex metabolic and endocrine disorder. These patients have high androgens, they have insulin resistance, and they don't ovulate regularly.
So how do we treat it? ICCHCs are listed.
We do. The combined hormonal contraceptives are great for regulating the cycle, and they can also reduce those high androgen levels, which helps with the acne and the hirsutism.
But the text also highlights metformin, the diabetes drug.
Yes. Even though it's not specifically indicated for ovulation induction, it's used all the time in PCOS to treat the underlying insulin resistance. By lowering insulin levels, you can often lower androgen levels, and that can sometimes restore spontaneous ovulation.
Fascinating. Now let's flip to the other extreme. Not no bleeding, but too much bleeding. Menorrhagia, or dysfunctional uterine bleeding.
This is where we see the non-contraceptive benefits of birth control really shine. CHCs stabilize the endometrial lining, so there's just less to bleed out. It makes periods lighter and more predictable.
But the text also lists NSAIDs here, ibuprofen, for bleeding. I always thought NSAIDs thinned the blood.
That's a common misconception. In this specific context, NSAIDs work by blocking prostaglandins in the uterine lining.
And prostaglandins do what?
They're what cause the intense uterine cramps and also vasodilation, which increases blood flow. By blocking them, you reduce both the cramping and the volume of bleeding by about 25 to 35%.
Which connects directly to our next topic. Dysmenorrhea, painful periods. It's those prostaglandins again.
It's the prostaglandins. They are the culprit. The uterus is a muscle, and it's contracting so hard that it's causing ischemia, a lack of blood flow to the muscle tissue, and that's what hurts.
So taking an NSAID, which is a PCOS inhibitor, stops the prostaglandin production.
Exactly. And that's why taking them before the pain gets really bad is so effective. If you wait until the pain receptors are flooded with prostaglandins, the drug just won't work as well. You have to get ahead of it.
Right. Okay, moving on to endometriosis. This is where endometrial tissue, the stuff that's supposed to be inside the uterus, grows outside of it.
The ovaries, the fallopian tubes, the bowel. And every month, when the hormonal signal for a period comes, that tissue bleeds too. But that blood has nowhere to go.
Which causes incredible pain and inflammation.
Extreme pain. So the treatment strategy here is interesting. You want to either starve that rogue tissue of the estrogen that needs to grow, or you just stop the cycle entirely.
So things like continuous CHCs or the depot shot.
Yes, those are first line. But for more severe cases, we use a class of drugs called GnRH agonists, like Leuprolide, which you might know as Lupron.
How did that work? GnRH agonist sounds like it would stimulate the system.
It sounds counterintuitive, you're right. Initially, for the first week or so, it does stimulate the pituitary, but if you keep stimulating it constantly, day after day, the pituitary desensitizes. It shuts down. It stops responding.
It gets tired.
It gets tired and shuts off. It stops releasing FSH and LH, so the ovaries stop making estrogen.
And you create a temporary chemical menopause.
Yeah, exactly. The endometrial tissue with no estrogen to feed it shrinks and stops bleeding.
But temporary menopause sounds deeply unpleasant.
It comes with all the symptoms: hot flashes, vaginal dryness, mood swings, and, critically, bone loss. That's why therapy with these agents is usually limited to just 6 months. We can't let their bones degrade too much.
The text also mentions a newer drug, elagolix.
Yes, that's a GnRH antagonist. It works similarly to manage pain, but is an oral medication specifically approved for endometriosis pain.
Okay, let's touch on PMS and the more severe PMDD. I was surprised to see SSRIs listed here. Antidepressants.
Yes, selective serotonin reuptake inhibitors like fluoxetine or sertraline. They are very effective for the mood symptoms, and you can take them every day, or, and this is unique to PMS and PMDD, you can take them just during the luteal phase.
So just for the 2 weeks before the period starts.
Right, because the symptoms are cyclic, the treatment can be cyclic too. It's very effective for the irritability, the anxiety, and the dysphoria.
All right, we've presented pregnancy, and we've treated disorders. Now let's look at part 4. Drugs used to promote fertility.
A huge shift in goals. Infertility is defined as the inability to conceive after 12 months of trying, or just 6 months if the woman is over 35.
And the first-line drug the book mentions is clomiphene citrate, Clomid.
A fascinating drug. It's in a class called SERM's selective estrogen receptor modulators.
So what does it actually do? How does it make someone ovulate?
It blocks estrogen receptors in the brain, specifically in the hypothalamus.
So you mentioned this before. It's putting a blindfold on the brain.
That's the perfect analogy. The brain can't see the estrogen that's circulating in the blood, so it panics. It thinks, we have no estrogen, this is a crisis, we need to make a baby, and it pumps out more GnRH.
Which tells the pituitary to release a massive amount of FSH and LH.
A huge pulse of them. And that huge pulse of FSH and LH is what stimulates the ovaries to mature and release an egg.
So it works by tricking the brain into thinking there's a shortage.
Precisely. But because you are revving up the system so powerfully, you have risks. The biggest one is multiple gestation twins, triplets. It happens in about 5 to 10% of pregnancies conceived with clomiphene.
The text also mentions letrozole.
Yes, which is actually an aromatase inhibitor, a drug usually used for breast cancer,
Mhm.
but it's used off-label for fertility, especially in patients with PCOS.
How does it work?
It blocks the enzyme aromatase, which converts androgens into estrogen, so it lowers overall estrogen levels, which has a similar effect to clomiphene. It tricks the brain into releasing more FSH.
Now, if the oral pills don't work, we bring out the big guns, the gonadotropins. These are injectable FSH and LH.
This is direct stimulation of the ovaries. This is potent stuff, and it carries a critical safety alert, OHSS.
Ovarian hyperstimulation syndrome.
This is a medical emergency. It's when the ovaries react too strongly to the stimulation, they become massive, sometimes the size of grapefruits, and they get very leaky.
Leaky.
The blood vessels become leaky, fluid shifts out of the bloodstream and into the abdomen, causing ascites, and even into the chest, causing respiratory distress.
So what are the key symptoms a nurse needs to watch for?
Abdominal distension, rapid weight gain like 5 pounds in a couple of days, nausea, vomiting, and shortness of breath. If a patient on these fertility drugs calls and complains of bloating and trouble breathing, you do not ignore it. It can be fatal due to blood clots or kidney failure.
That's terrifying. And I imagine there's a huge psychosocial component here, too, for patients undergoing fertility treatment.
Absolutely. The stress, the guilt, the financial burden, the roller coaster of hope and disappointment. Nurses need to provide massive support here. And practical education, too, like on timing intercourse. Remember, sperm can survive for up to 5 days, but the egg is only viable for about 24 hours.
So timing is absolutely key.
It's everything.
Got it.
Yeah.
Okay, part 5. We are moving through the life cycle. We have reached menopause.
The cessation of ovarian function. It's defined retrospectively after 12 consecutive months without a period.
And the symptoms are driven by that lack of estrogen. You get hot flashes, which the text says are due to an LH surge affecting the brain's thermostat, and you get vaginal atrophy and dryness.
So we treat it with hormone therapy, or HT. But the rules for HT have changed so much over the years.
They really have.
The golden rule now is use the lowest effective dose for the shortest duration possible, usually less than 5 years.
And there's a very specific, non-negotiable rule regarding the uterus.
The uterus rule. This is critical for nursing students to know for exams. If a woman still has her uterus, meaning she hasn't had a hysterectomy, you must give her estrogen and a progestin.
And why is that?
Because if you give estrogen alone, unopposed estrogen, it stimulates the lining of the uterus to grow and thicken. Without progestin to police that growth and cause the lining to thin and shed, it can turn into endometrial hyperplasia and, eventually, endometrial cancer.
So estrogen alone is only for women who have had a hysterectomy.
Correct. That is a hard and fast safety rule. Estrogen alone equals cancer risk for the uterus. Estrogen plus progestin equals uterine protection.
Let's talk routes again. We have pills, patches, and vaginal creams. Does the risk profile change?
It does. Oral estrogen has a first-pass effect through the liver. This means it hits the liver hard before it gets into general circulation. This process triggers the liver to produce more clotting factors.
So that's what increases the risk of DVT and PE.
Exactly. Transdermal options, like patches and gels, bypass the liver. They go straight into the bloodstream, so they generally have a lower risk of VTE compared to the oral route.
And vaginal creams or rings?
Those are primarily for local symptoms, vaginal dryness, painful intercourse. Because the absorption is mostly local, there's very low systemic absorption. So you often don't even need the systemic progestin, even if they have a uterus, provided the dose is low enough.
But not everyone can or wants to take hormones. The text mentions some non-hormonal options for hot flashes.
Yes, for women with a history of breast cancer, for example, SSRIs and SNRIs, the antidepressants, can help with vasomotor symptoms. And there is a brand new FDA-approved drug called fezolinetant, brand name Veoza.
How does that one work?
It's an NK3 receptor antagonist. It specifically targets the neurons in the hypothalamus that regulate body temperature. So it stops the hot flash at the neural source without using any hormones at all.
That sounds like a game changer.
Yeah.
And another one, bremelanotide.
That's an injectable for a different problem. Hypoactive sexual desire disorder. It's for libido, not for hot flashes.
And checking the boxed warnings for hormone therapy. It's a scary list.
It is. Cardiovascular disorders, breast cancer, endometrial cancer, and even dementia. This is why the risk-benefit analysis is so important and why we use it for the shortest possible duration.
Which leads us directly to our next section, part 6. Osteoporosis. This is inextricably linked to menopause because estrogen is a bone protector.
It absolutely is. Bones are constantly remodeling. You have osteoclasts that break bone down and osteoblasts that build it back up. Estrogen keeps the osteoclasts in check.
So when estrogen drops in menopause,
The osteoclasts go wild. They start breaking down bone much faster than it can be rebuilt.
so prevention starts with the basics, calcium and vitamin D.
Right. And the numbers are important to know. For women over 50, the target is 1,200 milligrams of calcium per day or 600, 800 IU of vitamin D.
But if that's not enough, we move to pharmacotherapy. The big class here is the bisphosphonates, alendronate, ibandronate, risdronate.
Nurses, listen up. The administration instructions for bisphosphonates are incredibly specific and vital for patient safety. You will see this on exams, I guarantee it.
Okay, lay them out for us.
First, you must take it on an empty stomach, first thing in the morning. Second, you take it with a full glass of plain water, at least 8 ounces.
No coffee, no juice, no milk.
Nothing but water. And then, this is the most important part, you must remain upright, either sitting or standing, for at least 30 minutes after swallowing the pill.
And why? What happens if they lie down and go back to bed?
The pill can get stuck or regurgitate back into the esophagus. These drugs are extremely irritating to the tissue and can cause severe esophagitis or even esophageal ulcers. Gravity is your friend here to keep the pill down in the stomach where it belongs.
So no coffee, no food, no other meds, and don't go back to bed for half an hour.
Correct. If a patient can't sit up for 30 minutes, they cannot take this oral medication, period.
There are other drugs too, right? Like the SERMs again, raloxifene.
Yes, raloxifene is clever. It acts like an estrogen agonist in the bone, which is good. It protects the bone. But it acts like an anti-estrogen, an antagonist in the breast and uterus.
Also good.
Also good. So it protects bones without increasing the risk of breast or uterine cancer, but it can still cause hot flashes, and it does increase the risk of VTE, just like regular estrogen.
And for very high-risk patients, we have things like denosumab.
That's a monoclonal antibody. It's a sub-Q injection given every 6 months. It works by inhibiting osteoclast formation.
Okay, let's wrap this all up. Part 7, clinical judgment and the nursing process. How do we put all of this information together in practice?
It all starts with assessment. You need a detailed history, a full menstrual history, obstetric history, sexual history, and screening for contraindications like smoking and VTE history is absolutely paramount.
The text suggests using the braided method for informed consent. That's a great mnemonic.
It's a fantastic framework to make sure the patient knows exactly what they're getting into.
Let's run through it. B is for.
Benefits. How well does it work? What are the good things about it?
R is risks.
What are the side effects, both common and serious?
A is alternatives.
What else could we use? What are the other options?
IV queries.
Give them a chance to ask questions, a dedicated space for it.
D is decision.
Let them make the final decision without pressure.
E is explanation.
Explain exactly how to take it, what to do if they miss a dose.
And the final D is documentation.
Write it all down. Document the conversation.
It's not just, here's a prescription, buy. It's a real dialogue.
It has to be. And patient teaching is continuous. Teaching the ACS acronym for CHCs. Teaching the upright for 30 minutes rule for bisphosphonates. Teaching that missed pills matter.
It really highlights how much education is the nurse's primary responsibility.
Absolutely. Compliance is so hard if the patient doesn't understand why they have to do these very specific, sometimes inconvenient things.
So, to recap our journey today, we started with CHCs hijacking the pituitary to stop ovulation. We saw how progestin-only options work for those who can't take estrogen.
Right.
We treated everything from missing periods to painful periods with hormones and NSAIDs. We tricked the brain with clomiphene to help women conceive. We then managed the estrogen drop of menopause, balancing that crucial risk-benefit ratio for symptom relief versus cancer risks. And finally, we protected the bones from crumbling.
It's a massive spectrum, the entire reproductive life.
And what really stands out to me, and maybe this is our final provocative thought for the listener, is the sheer complexity and, I guess, the duality of hormonal regulation.
It really is the double-edged sword of physiology, isn't it? The same hormone estrogen can be a contraceptive, a fertility booster, a cancer risk, or a bone saver.
It all depends on the dose, the timing, and the combination. It's just a reminder that in pharmacology, context is everything. Nothing is simple.
It's fascinating and terrifying, but mostly fascinating.
Agreed.
Absolutely.
Thank you so much for joining us on this last-minute lecture. We really hope this deep dive helps you crush your pharmacology exam or just understand the human body a little better.
Good luck studying. You've got this.
We'll see you next time on The Deep Dive.